Welcome to the Living Chronic Special Series, Military, Medicine, and the Mission Left Behind. In this powerful series, we're taking a hard, unflinching look at the cracks in the systems meant to care for those who serve. We'll examine the deep cuts to the military health system and how they're impacting service members, retirees, and military families. We'll talk about the VA, what's working, what's not, and the looming threats of cuts and privatization. We'll tackle the tough topics others often avoid: suicide, PTSD, gaps in care, and the devastating ways veterans and families are being left behind. You'll hear real stories, learn how to advocate for yourself and your loved ones, and understand the unique challenges faced by military and veteran communities. Our mission is simple: shine a light, spark change, and fight for the care and dignity our service members and their families have earned. We'll return to our regular Living Chronic content soon, but right now, if you've served or if you know someone who has, please share this series. Together, we can push for real change and make a real difference in the lives of those who've sacrificed so much. This is Brandy Schantz, and you're listening to Living Chronic. Today, I'm here with June Heston and Helen Perry. We are doing the special series focused on veterans, military, medicine, the mission left behind. Today, we're going to really focus in on the importance of having healthcare providers who understand veteran-specific illnesses, veteran-specific diseases, veteran-specific healthcare issues. This is a really great panel for this. June Heston, it was just instrumental in getting the PACT Act passed. For everybody who's not familiar, the PACT Act was the act most famously known as the act that John Stewart helped to get passed for the burn pits, gave us care for the various illnesses that we're getting focused on, that were caused by burn pit illnesses. June's late husband, Brigadier General Michael Heston, he died of a very rare pancreatic cancer that was caused by burn pits. So her advocacy work has just been amazing in helping to get us the care that we need post burn pit exposure and, of course, other toxins. Helen Perry, she's also a fellow Army veteran. We were both Army officers. She is a nurse practitioner, so she has some great familiarity with the military health system, and as well as the VA. She is also a caregiver for her husband, who is a wounded warrior. He suffers from traumatic brain injury, epilepsy, as well as a number of other issues. So welcome to you both. Thank you so much for being on the show. I think this is probably one of the most important shows we've done up to this point.
Thank you.
Thank you so much.
So June, I'll start with you. Of course, you know better than anyone how important it is to have a doctor who understands these kinds of unique issues that veterans may face that others don't, because we have been exposed to these various toxins, burn pit exposure, things of this nature that cause illnesses that other people living in the United States probably won't get. And that is how your journey for a diagnosis started with Michael. So tell me a little bit about that.
So Mike was in the National Guard for the Army National Guard for over 30 years. He deployed 3 times to Afghanistan, and in his last deployment, he returned in 2012. And in 2016, he started having back pain and was in a number of specialist offices, was going to at least 4 or 5 appointments a month to try to figure this out. We finally went for a second opinion to Boston. They were unsure what was happening. And then the doctors here in Vermont said, we can't figure it out. We don't know what it is, but it's not cancer. Referred us back to Boston. And after demanding a number of different tests that a friend of mine who is in the medical field said to request, after demanding the 5th or 6th time, they did an ERCP, and his pancreatic cancer was diagnosed 10 months after he started trying to figure out what was going on. And shortly after that, he started treatment, and someone sent me an article about burn pit exposure. And I I knew that this was an issue because the burn pit registry had been established, and Mike would say, if there's a registry, they know there's a
Mm-hmm.
problem. And so we started asking questions, and we went to Mike's oncologist at Dana-Farber, who said, burn pits, what is that? And when we explained, he did his own research, and he wrote a letter for Mike's disability claim. Mike was one of the very few that got a disability, uh, had to fight for it, but received a VA disability. And I'm certain it's because we pushed and we were in contact with our federal delegates, and we also were in contact with the VA. And he was a general officer, and I think uh, there was less fight because of that. And I believe that other people were not getting the same treatment because they didn't know how to
Right.
fight. And I just felt like we needed to do more for those who were being denied.
No, absolutely. And it's the same for you, Helen. You spend so much of your time as a nurse practitioner, a spouse, a very well educated woman, another similarly kind of pushy broad like me, getting the stuff done that needs to be done for your husband because there's just nobody else there to do it. So tell me a little bit about your story, both as a medical professional and a caregiver to somebody who has suffered so many very veteran specific illnesses.
Yeah, so my husband was in the Marine Corps. He was in infantry, and he did 4 combat tours. His second combat tour to Afghanistan in 2008, he was actually hit by 3 improvised explosive devices on the same day. They hit an anti-tank mine, 50 pounds of homemade explosive about 4 or 5 hours later, and then a secondary IED that was about 25 feet away. That was a smaller charge, but still pretty significant, and he was hit by that as well. And to give you an idea of the SAPI plates, the bulletproof vests that they wear in their vests are rated to 1200 psi. And the blast that hit Matt on the second blast was so powerful that it actually shattered his SAPI plate and turned it to dust. So when they opened up the SAPI container, it actually just like poured out sand. But in 2008, we didn't know what we know now about traumatic brain injuries. And so despite being very concussed, obviously affected by his blasts, and the number of casualties that they had taken. 2-7 was a very hard hit unit. They were doing a lot of combat in Afghanistan at that time. They were one of the first units back in Helmand province. He was returned to duty. They did a MACE exam, a military acute concussion exam that he didn't even fill out. Somebody else did for him because that's how concussed he was. And they sent him back to duty. And, when he came home, we thought he was just lucky not to lose any arms or legs. We were like, yeah, TBI, but like a little more forgetful, just whatever. We'll overcome like everybody does, right? Like I think it was pretty normal for us all to have known people who had TBIs and like, we just kind of brushed it off. And then in 2014, he had his first life-threatening grand mal seizure. And then several hours later, he had a second grand mal seizure. If you have back-to-back repeat seizures like that, it's actually you can go into something called status epilepticus, which is life-threatening. He was probably in that, but we didn't know because we didn't have good testing, similar kind of situation. And I was a critical care nurse at the time. And I was just like, 29-year-old male with new onset seizures, like this is like unheard of. Like this does not happen. And the civilian hospital that we were at was like, oh, it's drugs. And I was like, it is not. I actually demanded that he be tested multiple times to prove it. And then as things progressed, it was interesting as we started going through, and I started kind of trying to figure out why he was having these recurrent seizures. He was on medication. It wasn't working. He was getting worse, all these things. I was still active duty, that's another horrible story for another time. I was not treated well as a spouse and a dual military spouse. But I started looking into like what is causing this, and I started coming across studies that were talking about Vietnam veterans who were exposed to blasts and when was the likelihood that they would develop epilepsy. Because typically in the civilian world, when we talk about focal head trauma after a car accident, after a football injury, whatever, the leading sort of, medical guidelines is that they are most likely to develop a seizure within the first 48 hours after head trauma. In veteran populations, specifically who are blast exposed, it's actually 5 years later. And that we know now is because of the buildup of tau proteins for the microscopic shearing injuries and the diffuse axonal injuries that they get from these repeated head traumas. But I didn't know that, when I was, going through and working with Matt. So as I started to figure this out, the DoD docs and the Navy docs kept saying like, oh, head injuries don't cause seizures. And this is the phrase they would say to us: it's so rare, it almost never happens. I heard that phrase more times than I can count. And it was a similar story where I was like, no, like, this is not normal. This is not, he's not sick. He doesn't have, there's no lesions on his brain. We don't have, like all of this testing that we've done. Like, we don't have explanations. Once we got transferred to San Antonio to the Wounded Warrior Battalion, Matt was able to see an epilepsy specialist who was a civilian, but she had a little cohort of blown up guys. And I remember when we saw Dr. Morgan for the first time, and she was like, no, this is his head trauma. And I was like, what? And she was like, yeah, this is from being blown up. Like 100%, no doubt. And I was just like, but why don't the military doctors want to do that? And I remember she told me, and several other people told me this as well. She said, Helen, well, of course they don't want to admit to it because then they have to pay for it. And I was just like, no, but they care about us, don't they? And it's like, no, they really, unfortunately, don't. And it is a political thing, especially going through, 2014, going into 2018. There was a lot of emphasis for providers to sort of downplay, the impact of traumatic brain injuries and the long-term effects that we were seeing. And it's continued to be that way, even through his recent diagnosis of chronic traumatic encephalopathy and his, recent progression. We have struggled every step of the way. The only thing now is that I'm more educated and that I'm now I'm the one pouring through the medical journals. I'm the one doing the research. I'm the one pulling the statistics. I'm the one demanding the testing. And I've been able to use my, resources and my connections in the medical field as a civilian provider to find providers who very specifically have either experience or are willing to work with us to do the appropriate testing, to get the appropriate diagnosis. Because otherwise it just feels like gaslighting. I mean, and how many veterans have been told, oh, your TBI doesn't get worse. Well, you're right. Your TBI doesn't get worse unless you have a degenerative condition like CTE. And there's a huge emphasis now of providers who don't want to diagnose CTE because it has to be a presumptive diagnosis, meaning that we can't definitively diagnose until after, at postmortem after they've died, and we do brain biopsies. But in not having a diagnosis, you're not making families eligible for access to care and resources. Right. And that's horrible. I mean, and there's so many families, so many of these conditions are very specific to veterans. When you talk about blast and overpressure injuries and blast trauma and traumatic brain injuries, we have video of Matt being blown up in Afghanistan. They had combat cams with them. So we have video that shows the size of the blast. And we almost always show that to our civilian providers to say, let me show you what he was exposed to. And they go, no, there's no way he could have survived that. And I said, no, they do. That's very standard. And it's just this lack of training and awareness on the civilian side. And so, there's so many aspects about that it's so critical to have providers who are trained. Mm-hmm. I mean, I honestly think that medical schools should have like an entire tract that just educates people and upcoming physicians on veteran specific issues, their exposure to toxins, their exposure to burn pits, to, even just the vaccine regimens that they get. How many Americans do you know are getting smallpox vaccines still? Not very many, but that is a routine thing that we do. How many of them are getting, vaccines for yellow fever and things right? Like those are not things that we do typically in the United States, but that is something that we do for the military. Typhoid, for example. And there's so many different components of healthcare that are very specific to veterans that are just not the same in the civilian population. And so when we don't have that knowledge base, that concentrated knowledge base, these things frequently get missed.
Yeah, and unfortunately, that's the case for both of your spouses. And like we discussed earlier between the three of us, and we've all three had a little bit of this discussion between ourselves before, what are the people doing who don't have people like us on their side? June, you're a nonprofit executive. You also a fellow pushy broad. Not going to take no for an answer. Same, Helen, me. We're out there. We're breaking down doors. We're pushing to get the things we need. And when people, and to be fair, most people aren't like us. And thank goodness, if the whole world was us, we'd never get anywhere. It would just be a giant brawl. So yay for that.
Or we
yes. Yeah, or it would be so darned efficient, nobody would know what to do. I know. But here we are. This is reality, and we're all different people, and thank goodness for that. But even with us and all of the work we did, it took so long, for Mike to wait 10 months for a cancer diagnosis. That's unacceptable. To have to fight medical professionals and say, no, this is due to TBI. I need the appropriate treatment for my husband. That's unacceptable. So what do you think would have been some of the differences had there had been immediate access to a veteran-specific trained physician? Start with you, June.
Well, I'm not sure what the difference would be, because Mike was the deputy adjutant general. He was an estate physician, so his insurance was very good. I believe that there was a huge mistake made in that he went for his first scan 1 month after he had back pain, and they were saying, oh, it's muscular, it's this, it's that, and he was losing weight rapidly. And I feel like he, I know once he was diagnosed, we went through this for 10 months and he was diagnosed. What I didn't know, and I tell everybody now, is go into the portal and read everything. I didn't do that. I just assumed the doctors were reading it. It said right there on his first scan, possible pancreatic malignancy should be followed up on. It was right there. But Mike's this strapping military guy, doesn't fit any of the typical symptoms or have any of the behavioral stuff that would contribute to pancreatic cancer. So they didn't look for it. He did, I think, after going, because he wasn't eligible to go to VA, because, it's really hard to be seen unless you're in that priority 1 or 2. He wasn't there, so he's not going to be seen until after he was diagnosed. And then they're like, oh, yeah, pancreatic cancer. Like, wait a minute. So what happened after Mike passed away is he was very well known in the state, and our state legislature said, we need to do something about this. So they started working on legislation that would make our veterans aware of what toxic exposure is, what it's doing. And the piece of this legislation that was signed into law in 2019 said our health department needs to communicate to every health provider in the state that they have to ask, are you a veteran and do you think you've been exposed to toxins? Now it's just kind of getting off the ground. That was 2019. But right now, the VA Department of Health and our UVM Medical Center mental health department, because of suicide, they are putting together an intake form as a pilot, and we're working on how this can happen across the state and hopefully across the country. Everyone in every medical provider's office, that intake form should say, are you a veteran?
Yeah.
And tell me about your experience, because that changes what they will look for.
Yeah. I think also it's educating veterans too on toxic exposure, because
Yeah.
everybody instantly thinks of burn pits, which have had a lot of media
Yeah.
attention. But if you've ever
Yes.
walked a flight line, if you've ever
Yes.
stayed in a barracks that's pre Vietnam, which I
Well,
mean, I did. 2011, I stayed in the barracks on North Fork and at Joint Base Lewis McChord. Those were the same barracks that my dad went through before he deployed to
yes.
Vietnam. Those were
Yes.
asbestos level barracks. When I was at Walter Reed, I walked into work one day to people wearing hazmat suits and respirators as they were tearing. And this is a Walter
A
Reed
premier
hospital
hospital. Yes.
tearing a premier hospital, tearing out asbestos, and they had this huge sign. They had it all roped off. These guys and these like they had like Geiger counter. They had the whole thing, and they were like, "Oh, we're removing toxic materials," and I was like, "Why do you have a respirator and I
Right.
don't?"
And
Right?
this is the
You think
hospital that
about
takes care of the president, by the way, for those who don't know.
yes, it is. It is. And
Yeah.
that was right at the pharmacy
Oh,
entrance.
good.
So the pharmacy was right there. Right. So there's like people just sitting there, getting just breathing this all in. And then you think about, recently I saw pictures of the California
Hmm.
wildfires where National Guard had been deployed and they were standing
Yes.
out there without
That's
N95
right.
masks. And I even wrote on one of the Army women groups, I said, hey, if you have soldiers who are deployed, please make them aware that if they are not being issued N95s, they need to be. And if they're not being issued these masks, they need to document that, do a video, do pictures, do whatever they need to do. That is
Yes.
toxic. I, you
Yep.
know, I like those are toxic. There's a reason that our firefighters continue to wear respirators. Floodwaters, right? Floodwaters have an insane amount of toxic exposure. So if you're National Guard and you're wading through floodwaters and then they don't replace your
Yes.
uniforms and you're continuing to wear, there's all of these things like that increase your toxin exposure in the military that we just don't think about because we think about Iraq or
Right.
Afghanistan or Syria or
Right.
whatever. And it's like, personally, I think that as a medical provider, I would just assume that they all have toxic exposure. I think that's the safest
Yeah.
thing to do instead of asking people because I think for so many of them they just don't
Right.
know.
Right.
And I also think that medical providers need to be better trained on what that toxic exposure means, right? Because it's not just cancers, right? It's
Right.
tetragenic effects for
Hmm.
pregnancy. And we know that the rate of autism amongst military families is significantly higher. Now, is correlation causation? Maybe, maybe not. That doesn't necessarily mean that being in the military makes you more likely to have an autistic child, but we know that there's significant impact. And we know that some of those toxic exposures can impact pregnancies and cross the blood-brain barrier and do
Hmm.
these, all of these things.
Right.
You look at the rates of ALS, right? ALS is significantly higher in the veteran population. And yet, I have personally worked with young veterans who came into the hospital with symptoms of ALS, of rapid onset ALS, which is also a
Okay.
thing, and had civilian providers say, no, that's not a thing. And I said, it is. Google it. Like, you don't know about it because you're not working with veteran populations. But I worked at Walter Reed where NIH was across the street and we were getting ALS patients in and we were
Right.
seeing this regularly. There's so many things that get it, a lot of it is also just educating medical providers on what it means for these individuals who have, how do we do that screening? Do we continue to use the public health service recommendations for screenings with veterans, or do we maybe need to tweak that a little bit to do more veteran specific? For example, if you have a traumatic brain injury, you are, I think it's twice as likely to get brain cancer than somebody without a traumatic brain injury. Now, does that mean that we do more CT scans, which could therefore increase your
Right.
risk of getting, right? There's all these
Right.
things, but I think it's something that we need to look at of how do we screen these patients? Do we need to do early colorectal screenings? Do we need to do pancreatic screenings? Do we need to do more screenings for, leukemias and bone cancers and things like that, knowing that those are all increased rates in the veteran population? But I think that the hard thing is when the VA is the one doing the advocacy, all of these things come with dollars and
Yes.
cents attached to
Yes.
them. And when we are letting budgets drive best practices, we are never going to end up with best practice. And there has to be balance there to help facilitate. And I think that's one of the big struggles that we're currently experiencing, is that right now budget really is dictating care.
Absolutely.
And we're seeing that in so many families. I mean, I'm sure, June, at some point somebody said, well, you know, an ERCP is an expensive procedure. He's got to get sedation. And you were like, yeah, we're fine with that. But like, do the thing that we need.
That. They like, I'm asking and asking. They didn't even say that. They say, well, we'll try this. Like, but I, you know, and I did push back often, but you know, they were like, well, we're gonna look at this, because he just wasn't a good candidate for pancreatic cancer. He didn't fit the mold.
Yeah. But had they known about the increase in cancer diagnosis in veterans with burn piss and toxic exposures, then they should have. And the weight loss, you said the rapid unexplained weight loss. If you come to me and you say nothing else other than I have rapid unexplained weight loss, you are immediately going to get screened for cancer. Like that in and of itself is like the thing that sets it apart. And it's so unfortunate. It's so unfortunate, because we see that so often, where people say, you know, I started losing weight a year ago and I thought I was getting old, or the doctor said I was getting old, and my you know, my metabolism's changed. You know,
Go ahead.
I was going to say, they come up, I've heard every excuse in the book to explain the weight loss of, you know, I started a diet and then I lost weight and everybody said it's just the diet. And I'm like, no diet is that good. Like,
right. Yeah. And 4 months into it, I thought I was going crazy. I said, I feel like he's dying and I'm the only one that sees it.
Yeah.
And when we did finally went back to Boston, they were like, okay, well, let's come back in 3 months and have him tested again. And I said, 3 months? I go, and you think he's going to be alive in 3 months? And I pulled a photo out. I go, this is what he looked like a year ago. And then they ordered the RCP and all these other tests. And I'm thinking, oh my gosh, like, why did it take this long?
Yeah.
And again, you know, they are civilian doctors, but he couldn't get into the VA. And that's the problem, is so many of our veterans aren't being served by the veterans care. So we have to educate everybody on this.
Yeah. And I think there is, you know, I think one of the factors that a lot of people don't consider when we talk about veteran care is that a lot of them do get care in the civilian sector. And our civilian medical sector is collapsing.
Yes.
I am saying that as a healthcare provider. I am saying that as a prior nurse. I am saying that as somebody who worked through COVID. Our healthcare infrastructure is in free fall collapse at the moment. And it has been for many years. This is an ongoing, it's just getting worse. But when you
it will get even worse.
It will get worse. It will get worse. And I think that's the thing. Like, I tell people now, if you have a loved one going into the hospital, I don't care how minor it is, take someone with you. They need to stay with you the whole time, right? Because it does not matter the hospital that you are at. It does not matter the name, the prestige, the magnet status. It does not matter. They are short-staffed. Those nurses are overworked. They are underpaid. They cannot keep up, no matter how good they are, no matter how amazing. And if you have a wonderful experience, then I applaud you, and please let them know. That's great. But more often than not, you will find that they cannot keep up with the amount of work that they have. And that is how bad things happen. That is how little things turn into huge things, because a sick individual cannot advocate for themselves the way that somebody can who's clear-headed, who's not undergoing all those things.
Right.
And, you know, we've experienced that very recently. My husband was sent to the emergency department. I could not be there instantaneously with him because we have small children. So I was about an hour behind in getting to him. In that hour time, they gave him a medication that, had I been there, I never would have allowed them to give him. And it interacted with some of his seizure medications, and he went into a medically induced psychosis. That was horrible for him. He is traumatized because of it. He literally went crazy. Like, that's what that
Yes.
means. He got medication
Well,
that made him go crazy, and he
yes.
did go crazy. And had I been there, it would not have happened, because I could have said, no, 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 no. That med is known for doing these things. He's taking these other medications. I don't think that's a good idea. That's not in line with what his neurology team wants to do. That was a small thing, right? That's a trained medical provider, and he just can't advocate for himself, right? And so these things, and that's a mild example of terrible things that can happen. But that's our healthcare system
And I
right now.
think that's important to
It's
point out because so often, and look, I've been in the military medical system of some type, whether it's the military health system itself, TRICARE, or Veterans Affairs, for 5 decades. I was born in the military. My father was in the Navy. So I've been doing this, for a very long time, and we hear all the time, whether it was when you were a kid hearing your parents say it, or as a military person on active duty, or maybe you're now out and you just hear bad things about the VA. Whatever it is, we always hear, oh, TRICARE's terrible. It's so much better on the outside. Oh, military health system's the worst. They just don't know anything. They don't do anything. It's so much better on the outside. And you hear that over and over and over again. But what I have found through some terrible experiences that I never wanted myself is it's not better on the other side. As a matter of fact, it's considerably worse and getting far worse each and every day. They don't have space for us. They don't have the time for us. They don't have the kind of training that they need to understand veteran-specific illnesses. And you know what? It is important that we train them, but who has time? When does this happen? Because we're short on everybody and everything. I can't even get physicians trained up properly on the very many different side effects and reactions you can have to a medication that they prescribe. I am a victim of that. I had a very severe reaction to Humira. As a matter of fact, again, through my own pushing and fighting, I've learned that all of my problems stem from, apparently, Humira can also cause MCAS, which nobody's ever told me. And when I found that out, I thought, well, that's just a thing that's known? Yeah, it's well known. Well, not well known, I guess, because I just now finally am getting to the bottom of that after years of severe nervous system issues and barely being able to function. So I think it's very important that we talk about that. That greener grass, it's just not there. It's just not there. So when they say, well, let's just privatize the VA, it sounds great when you believe there's some greener grass somewhere. But again, there's no green grass. It's much worse.
If you look at what happened, during COVID, I've seen different numbers. Some say that 500,000 nurses resigned. Others say that it was more like 300,000. I've seen numbers that say up to like 120,000 physicians early retired. And then you look at the number of physicians that are coming out of residency programs that are, going into the workforce. You look at what's happening to the military health system as it significantly draws down its infrastructure and its ability to treat patients. You look at the number of federally designated critical healthcare shortage areas across the United States, how many of those areas overlap with military bases, right? All of these things compound so that you just really can't get care anywhere. And then what happens is people utilize emergency rooms, which is not a great place to get care. It's terrible, especially if you have a chronic disease or you have a very specific disease, right? Like that is the worst place you can go. No offense to my ER colleagues, like they are very good at saving your life in an emergency, but like they're not great at everything else. And so we're seeing this like rapid utilization of emergency rooms and urgent cares. Urgent cares can be a very mixed blessing for people. They can miss very serious diagnoses and they can, overtreat other things. Like that's also a mixed bag. But it's just our healthcare infrastructure in general that's failing. And when it fails, it also fails veterans. And that's, I think, the thing that people, when I talk to people and people say like, oh, I, support the veterans. And I'm like, great. Then like, support the programs that support veterans, because that's all of these other things.
Right.
And creating the education, I've gone out there and done education for people on, for example, one of the ones that it drives me nuts is the assumption that post-traumatic stress and TBI are the same thing. Right. Everybody who served a day in the military is like, nope, not the same thing, but the symptomology particularly overlaps. But the thing that providers don't know is how to tease that
Right.
out and how to figure out,
Right.
is your avoidance of public spaces because you're hyper vigilant and you're afraid you're going to get shot? Or is it because you're overstimulated by the noise and the activity and you can't regulate through the mental processes to navigate that
Yeah.
situation? One is traumatic brain injury, one is post-traumatic stress. And so it's, creating the programs to do the education. Like, I would love nothing more than to travel to conferences across the country and educate people, but that costs
Yeah.
money.
Yeah.
And that money does not exist. And
Right.
it's getting, the money that does exist for those
Getting
kinds of things is
smaller.
getting smaller and smaller and harder to access. And so then
Exactly.
everybody's like, well, then, how are they going to know? And da 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 da. And it's like,
Right.
this is where we are.
And you bring up a good example. So PTSD now, the VA knows there is a connection between toxic exposure and PTSD.
Mm-hmm.
The VA knows.
Right.
I don't think our general practitioners have any idea that that's a possibility.
Well, and I
No,
think
I don't
PTSD
think
as
so.
well. It's so misunderstood, and there's a lot of assumptions made. I myself, I always found this interesting. I was seeing civilian neurologists trying to figure out what the heck is wrong with me. Otherwise healthy women in their 40s don't just, lose their ability to run and suddenly can't speak correctly and, lose parts of their memory and start having tremors. This isn't normal. And there was a pretty good number of them who had no idea what I did in the Army. They did not know my specific background in the Army, what my experiences were. All they knew was I was in the Army and that I had been deployed to Afghanistan. And I had more than one just assumed that I had PTSD from my generalized service in the Army. And therefore, that was what was causing my issues. And I thought, my goodness,
Right.
is this where we're at? Am I are you afraid I'm just going to commit suicide right here in your office because of it too? Or, what other stereotypes are we working with today? Because
Right.
there are very specific types of PTSD, different causes that are not all combat related. As a matter of fact, as I like to
Yep.
point out to people right now, the biggest trauma issues I'm having that are affecting my life in a major way are medical trauma issues, because now I've found that I am having
Yeah.
a very difficult time advocating for myself because I start panicking when I get into certain situations in medical context because I've been through so much trauma medically over the last 5 years. It has nothing to
Yeah.
do with my combat time at all. And so
Right.
those things are very important and specific as well that we're not talking about. And it's not the
Right.
stereotype.
Right.
Well,
people
and I mean,
believe.
it's, I will even say that it was similar for me. All my time overseas was done as a humanitarian. So I've been in Iraq, I've been in Syria, I've been in all these places, but I never did that with the military. But like, potato,
Right.
like it was all kind of the same. But I worked with a lot of combat wounded at Walter Reed and at Fort Stewart, and then again at CMC. And I will tell you that trauma does not have to happen in a war zone for it to be combat related. Like, when you're doing those kinds of things, I think it's interesting that like everybody has kind of acknowledged like the trauma that drone pilots go
Yes.
through when they're thousands of miles away and doing their job, but nobody
Yeah.
wants to talk about how that impacts the military nurses who are doing the medical evacuations and working with these guys every day. That's a whole other TED talk that I could get into. But I think, part of the challenges that we're seeing on the advocacy side is, like you said, we've put these stereotypes, we've created these boxes of like, this is what PTSD looks like, this is what it is, this is what people should look for. And we're really not doing a justice to anyone when we're creating these very rigid, sort of algorithmic like care, patterns, instead of just helping people understand the lived experiences of veterans, what the different jobs are, what does it mean? What's your risk of TBI if you're a mortarman versus a tanker versus, say, like a driver, right? Because drivers got a lot of attention for TBI exposure, from IED blasts, and the transpo guys got a lot of exposure, screen the transportation
Yes.
guys, right? In fact, the VA actually created a list of MOSs that should have been screened for their risk for overpressure injuries. But they forgot to talk about people who were in and around the artillerymen or in and around those positions. Like, they just didn't think it through because it wasn't really military members who were creating these lists
Right.
of things. And really doing the advocacy to say, like, well, like, maybe we should look at the mortarmen. Maybe we should look at, not just the infantry guys, but the guys who were, O351s, which don't exist anymore for the Marine Corps, but those were shoulder-mounted assaultmen who were carrying, like, rocket launchers, essentially, and those dudes are all concussed. Talking to cav officers who actually did cavalry operations on horses because they fall off the horses frequently, right? Like, there's all these things that it's like, that we just haven't thought through. And then when we don't educate civilian providers, they don't see the connection. And because the healthcare system is failing, they just get so caught up in these, like, yeah, but, like, did you get your breast cancer screening? And did you get your colonoscopy at 45? And, like, did you get your flu vaccine this year? And it's like, we're just trying to push people through this broken system, and we're not doing anybody. And the gaslighting is terrible. And helping patients get through the gaslighting is like a whole, that's a whole series in itself, right? Of, like, how to advocate for yourself and the questions to ask, and how to get that documented in your records when they are very clearly gaslighting you, all of these things. Like, it's so hard for families now to take these fights on, because on top of everything else, now they have to be an expert in how to utilize healthcare in America.
Right. And it's especially important now because with the potential cuts in Medicaid, that's 1.6 million veterans.
Yeah.
That will be affected. And that's going to grow because they're not going to get care because they can't get care and their conditions are going to get worse.
Yeah.
And so this is going to be this never-ending cycle if people don't now say, "Oh, I've got to think about this now," because down the road might be too late.
Yeah, the healthcare avoidance. We are still today seeing the impacts of healthcare avoidance, which is basically people just delaying care from COVID in 2020. And it's 2025. And we are still seeing the people in intensive care are just getting sicker and more sicker and more sicker and more sicker and have more compounding comorbidities and having more delays in access to care because the system is so bogged down. And that is only going to get worse as these cuts take place and as cuts continue to take place in the Veterans Administration. Because when veterans can't access care through the VA, where do they go? The civilian emergency
So we're just
room.
adding to the problem.
Right. Exactly.
We are. It's
As somebody who's had a severe medical issue over the last 5 years, what luck did I have when all this started February 2020? But, if you want to know about how bad our medical system is, just ask me, the lady who has gone through so many medical issues over the last 5 years, and who, by the way, had a lot of really good insurance and a lot of cash sitting in the bank account to just pay out of pocket, because that's what I have to do sometimes. And, the whole host of other things as I sit here in the Washington, D.C. metro area surrounded by top professionals. It's not easy. I remember when when I first completely lost my ability to walk, and I had been doing this slow downhill, and now I can't walk, and I'm laying in bed, and I can't walk. And I'm trying to get in to see a specialist, and they said they were going to rush me in. Thank you. And they said, here's your appointment date, and it was 6 months later. I said, excuse me, is that the rush? Yeah. Can we get anything closer? So, well, only for emergencies.
Yeah.
I can't walk.
I can't walk.
What do I need to do here? How much blood do you need to see?
Yeah.
What happens? And that's the part that people just aren't seeing. So I think, to my mind, as somebody who is very close to this and who sees, what goes on day in and day out and the boring, crap of policy stuff that nobody really wants to read through. If you have been exposed to toxins, stomp your foot here, hit something, everybody. If you're a veteran, you've been exposed to toxins, you're eligible for care at Veterans Affairs now. So that passed, what year? Does anybody remember what year that passed?
2022.
Thank you, June. 2022. you are eligible for Veterans Affairs Cares. So go in there and register for it now, and make sure everybody you know who has ever served, I don't care if you were only on active duty for 1 day, get in there and register.
Yeah.
Because we need more of these VA hospitals, especially in the various states. Because June, like you've pointed out many times, these National Guard and Reserve soldiers, they aren't right next to a big base like, or Walter Reed or anything like that. They're out and they're depending on the community. And oh, by the way, many of these soldiers, sailors, Marines live in areas that are very rural medical deserts. They have nothing. And a Medicaid cut means they lose their few medical providers they have. That one hospital that's a 2-hour drive away is now gone. So how do we take care of veterans in those situations? We get more VA hospitals out there. So the more of us who register, the more of us in the system, the more of us who demand care and say, we have earned these benefits, you promised to take care of us, we are sick, take care of us at VA hospitals using doctors who understand veteran-specific issues. That's what I keep saying to everybody, because I want to, and I try my best to educate doctors in many different ways. Like you, Helen, I go around, I speak at different medical conferences, things of that nature. Sometimes I'm talking about veteran issues. Sometimes I'm talking about various issues with the adverse reaction database, different drugs, just being a patient with both dysautonomia and Crohn's disease, whatever it may be. But it's going to take a long time to educate all these doctors, especially when they're so overworked. But what we can do to get veterans care is by getting us more doctors at the VA, more nurses at the VA.
Yeah. And I would add to that, the thing that veterans can do right now, even if they have TRICARE, if they're using the VA, if they're using civilian healthcare, if you are a veteran and you are experiencing any level of challenge with accessing healthcare, whether that's in your community, at hospitals, bad care, can't get your prescriptions covered, whatever it may be, is write your elected officials to make them aware. You don't have to ask them for help. You just need to say, I am a veteran, I live in this area, let me tell you about my experience accessing healthcare. Because as an advocate, that is one of the biggest challenges that I run into is elected officials saying, we're not hearing that from our constituents. And it's like, well, one, you're not asking, and two, people just don't think that they're listening, but they are. And we need to start hammering them. If you are military and you are having experiences, you can absolutely write your elected officials and let them know. If you are a veteran, 100% write them every day. There's apps now you can text, you can email, you can send letters. But we need to be advocating and making them aware, because otherwise they just say, oh, it's fine. There's no problems. Nobody's written to me to say they can't. So therefore it must be okay.
And they all have staff to deal with Veterans Affairs.
Yes, specifically. Yes.
And be sure to know who your person is. I won't inundate my favorite staffers by name dropping them here, but you can always reach out to me and I'll help you find yours. But it's important. It's important. If you're in DC, go to the people's house, schedule an appointment, walk in there, knock on the door. Hi, I'm Brandy Schantz. Nice to meet you. It's probably not going to be your representative. Don Byer's off somewhere, but his staff's in the office and they know me. Stop in, tell them what's going on with you, what issues you're facing. They see me all the time. As far as I know, they still don't hate me. So, they might. Maybe they're like, God, not her again. But
but the important thing is even if it's not something that you're experiencing, somebody else is experiencing. And if you think you're the only one, I promise you, you're not. And it's making elected a leader. The other thing is, for active duty service members who are experiencing struggles accessing care, please write your leadership at the Pentagon and the Department of Defense. Like, be that person that says, hey, this is unacceptable, because the cuts are dramatic and they are going to affect access to care. And it's if you talk to anybody on the healthcare side of the house, they will tell you that these are catastrophic cuts that are coming, that have been implemented since 2013 through 2015 and now moving on. And we really need to raise awareness. And it's as easy as sending an email. Hey, this is what's happening. This is why we can't access care. This is what has happened to us as a veteran family. This is why we need more programs to support thank you very much, signed your name.
Right.
And I think that that is something we can all do to just help start the process of change.
Yeah, and I think knowing that the Congressional Budget Office is banking on these new rules, like that you have to do your renewal for Medicaid every 6 months now instead of every year. It's cumbersome, and so people who are eligible will not get Medicaid because of this cumbersome process. And don't let them get away with that. Like, keep fighting for what you've earned.
Absolutely.
Yeah, absolutely. Yeah, defunding the programs, a lot of people will talk about like, oh, well, those programs exist. And I'm like, but do those programs have
that's
money?
a more important question.
Because that is how that's how people get treatment and care, is there has to be money. Substance abuse programs are a prime example of that. Like, all the states have substance abuse programs that are state and federally funded. But if those programs have had their bed, capacity used up, sorry about your addiction. Like, that is an issue that predominantly affects veterans at a significantly higher rate than the civilian population. And then people wonder why their loved one has to get sent six states away to find access to a substance abuse program. And it's like,
right.
And a good thing to bring up at this point too, and this is, whether you're a veteran, a spouse, on an active duty base, wherever you are, get involved in the state politics. Everybody wants to get involved in DC, but there's so much that happens at the state that's so important. And I didn't realize it myself until I became involved in the state. And I realized that even the federal funding that you're receiving in your state is often dependent upon how much your state wants, because you have to match it. So often states just completely turn away dollars because they don't want to match those dollars. And then people say, well, see, the federal government's just not funding any of this. So, off with their heads. Well, look to your state government and get involved. There's so much that can be done at your state level, and people just aren't getting involved. And if you're a military spouse and, you're upset by some of these things, get involved. Put the kids in the car, drive to your state capital, meet with your representative there, talk to the veterans liaisons there, get involved, because a lot of that funding is coming through the state, and it depends upon what your state's doing if you're going to get that funding.
Yeah.
That's a very good point, because right now with these Medicaid cuts, they are going to be dependent on state matches. And there will be states who say, yeah, we're not going to do that. Well, that can't happen. So that's why it's really important to get involved locally. And oftentimes that local stuff goes nationally. People are paying attention, but you have to speak up.
Yeah. Well, I think also having people ask, when they're running into barriers with care, whether they can't get a referral to somebody on the outside, whether they can't, whatever it may be, I think just asking the question of like, why? Why is my referral 6 months out? Oh, because the clinics that were funded by Medicaid and Medicare have now closed. And so now you're the only provider in the tri-state area that is seeing oncology patients, or, whatever it may be, right? Like, asking that question will help you understand, because the VA had 3 TBI providers that now is down to 1 because they had a hiring freeze and then they laid 2 of them off. Oh, good to know. But that definitely is not an impact in my care, according to, different individuals. So we got scheduled a year out for a TBI appointment, right? Like, if you just ask why, a lot of times you're going to be like, oh, I had no idea that was an issue. And it will help you drive, like, again, in that advocacy to say, hey, like, this is why we can't access care. And the why is also what helps you find the solution, right? Like, that's... Right. And I think that it is hard to do because it is a complex system, but, why is always a great follow-up question for any issue that you're experiencing in the medical field, for veterans to just have a better understanding. And if what they tell you doesn't make sense, pop it into Google or Chat GPT and see what it tells you about that situation. It's an easy way to learn about how these processes work, because it is complicated, and we can't expect everybody to just be, magically Medicaid, Medicare experts. But you got to understand it, because that's what drives your access to care.
Right.
So.
Yeah, we could probably talk about this for another 4 or 5 hours and then come back next week for some more topics. But, thank you for being on. It's so important for us to talk about, especially these veterans specific illnesses and veterans getting the care they need. I will be the first to admit that the VA needs a lot of work. I would love to myself get in there with a lean Six Sigma and get to some real, dirty work, because there is a lot that can be improved upon. But that being said, it's also the place where I get the best care for many of the illnesses that I suffer from. And again, that's a benefit that I earned. For those who aren't, aware of the shortages and what's going on in the civilian medical healthcare system, I'll say this: there's doctors right now who spend a very small percentage of their day being doctors and the rest of it doing bureaucracy, fighting insurance, trying to jump hoops, trying to meet various, numbers that they have to hit for whoever owns their practice or their hospital. They have to meet so many, procedures each month, see a certain number of patients. They're doing everything but focusing just on your care. And my doctors at VA are government employees. They wake up in the morning, they show up at work. Their job is being my doctor. And then when they get off work, they go home and spend it with their family or doing some light reading, all focused on stuff related to being my doctor. And that does make a pretty big difference in your care. When you have a doctor who's able to be a doctor because they're a government employee employed as a doctor versus somebody making money for whatever the for-profit
Right.
system is that they're in.
Well, and one thing people probably don't consider is that your VA facilities are federal healthcare facilities. So they frequently are not subjected to the same state regulations and some of the same federal regulations that impact civilian hospitals. And because of that, there is a degree of ease that comes with not having to jump through as many of those hoops, or being able to expand, for example, the autonomy and the autonomous practice of, say, nurse practitioners or specialized nurse practitioners. A great example of this is that the VA actually created a fellowship program for addiction medicine that nurse practitioners could attend. And so those nurse practitioners were fellowship trained, which is a big deal, in addiction medicine, and then able to practice autonomously, in those clinics. That is not something that anyone anywhere else has been able to do because of state and federal regulation, but the VA was able to do it. So there's so many opportunities to facilitate better care for patients in so many different ways that the VA does have incredible opportunity. But in order to get that opportunity, we need intelligent, educated advocates at the table who are knowledgeable, not just in medical care, but also in the lived experience of veterans. And that's how we're going to make meaningful, impactful change. It's not just having the medical staff there. We need the community, the veteran community, to also be present at that table to make those changes, to advocate for the changes that we want to see for ourselves and our loved ones.
Now, well said. Thank you so much. For anyone who's interested in becoming an advocate, please reach out to the show. I will also be adding tools that you can use to contact your representatives. Be sure to stand up, demand what you've earned. We need better veteran care. Thank you again, June and Helen. This has been a great show. You've been listening to Living Chronic. That's a wrap for this episode of Living Chronic. I hope today's conversation gave you insight, inspiration, or at least a little reassurance that you're not alone on this journey. Living with a chronic illness or disability comes with its challenges, but it also comes with strength, resilience, and a community that understands. If you enjoyed today's episode, be sure to subscribe, leave a review, and share it with someone who might need to hear it. You could follow me on Instagram at Chronically Brandy Schantz, other socials at Brandy Schantz, or my website at brandyschantz.com for more discussions, advocacy updates, and everyday strategies for thriving with a chronic illness. And if you have a topic you'd like to hear about, send me a message. I'd love to hear from you. Until next time, keep pushing forward, keep advocating for yourself, and remember, you are more than your diagnosis. You are powerful, you are unstoppable. Thanks for listening to Living Chronic. See you next time.